Hi everyone, I'm Amina Ahmad from Nigeria. I'm the founder and CEO of Datharm. I would like to walk us through some of the implementation experiences uh, using MCH Track. That's the name of the platform we developed on CHT framework. Next slide. Okay, I'll take us through the background of the community engagement strategy and some of the challenges we're trying to address, the tool we developed, which we call MCH Track, some hierarchy and process flow, do a demo of both the mobile application as well as the dashboard, some of the impact and challenges we faced. Next. Next. Next slide. Yeah, so this is Magaji Erakuma. He's a village head in one of the first communities we deployed this application in. Just wanted to give you context on some of the stakeholders involved in this community engagement strategy. So the community engagement strategy in northern Nigeria has gone far and has been very impactful in terms of increasing routine immunization coverage. But there are some challenges involved. The elderly gentleman I showed you in the previous slide is one of the lead in community engagement strategy. He and similar stakeholders in different communities like that as village heads are responsible for manually enlisting members of the communities that are either newborn babies or pregnant women. They have a register in their house for that, and they are also responsible for referring and tracking those caregivers for routine immunization and other PHC services. On a monthly basis, the village head as well as the facility sit down for what they call a reconciliation meeting. During that meeting, what they do is reconcile the data of the register at the facility as well as the line list register by the village head to track who has gone to the facility and who has not. So eventually coming up with a list of defaulters. Like I mentioned, it has been a very positive and impactful strategy, but there were some challenges. One of which was the manual reconciliation processes, the time inefficiency. Of course, anything manual comes with error-prone record keeping. And then because the village head is working on a volunteer basis, there is no financial incentive. And sometimes it requires him to not just time, but to travel to the health facility or to some of those non-compliant household to carry out his or her his task. It requires some financial resources or commitment. So some of these challenges were what we identified, and our approach was to leverage technology to see how we can strengthen the process as well as also streamline some of the workflows. Next. So this is the intervention overview. We tweaked the stakeholders. So instead of leveraging on the village head to carry out all these activities of line listing and tracking, we tweaked the stakeholders a bit to work with female community resource groups or volunteers that are young, at least secondary school leavers, so they have a diploma. Literacy won't be an issue. I forgot to mention that reading and writing was usually an issue with the previous stakeholder, but with this, they have at least basic understanding of English or Hausa, that's the common language here. And then they were able to read and write or document data in their register. So we empowered them with a mobile app we developed. We call it MCH Track. It's built on CHT. They use that to go to households within their settlements, line lists pregnant women and children, and then refer them while recording the referral using the application, counsel and refer them to health facilities. And once the referred caregiver goes to the health facility in charge or health worker, sometimes we use record officers, record the service rendered. And with that, automatic reconciliation happens. So we have reconciliation of the community data with the health facility data. If in any case within 14 days, the referred caregiver doesn't go to the health facilities, the system tag that particular person as a defaulter, and a notification is sent out to the community resource person or mobilizer responsible for that referral that so and so within your settlement has not gone for this particular service. And it's because it's a name-based strategy, she is aware of exactly where that person is. As all this is going on, we have a dashboard that visualizes the data at local government level. That's our structure in Nigeria. We have local government, state, and national. So there's a dashboard at local government level, state level, and also at national to see exactly what is going on. I'll showcase that in the next couple of minutes. So with this strategy, we're able to know who these children or caregivers are, where they are actually located because it's geo-tagged. And then also we collect some, apart from the quantitative data, we collect some qualitative data in terms of barriers to service uptake. So if we have a defaulter, why did this person default? All this is visualized on the dashboard and is used by different stakeholders to make informed decision in terms of planning, outreach services, or other interventions within those targeted communities. Next. So this is the hierarchy, the mapping we have done for the users of the platform. Starting from bottom up, we have settlements that are mapped to community mobilizers. A community mobilizer might have one or two or even more settlements, but regardless of the number of settlements, there is a mapping to the responsible community mobilizer. And then a health facility also will have community mobilizers attached to them. So this is how it looks like. The settlement, community mobilizer, health facility. If we are to go up further, health facilities are located within a local government. So there is that mapping as well, a local government to a state. Next. This is the process flow. I've already discussed most of this, but just to show how this looks like, the first step is the community mobilizer interacting with the household, getting information, logging that information on the application, and then that is transferred to our server. Once the caregiver goes to the health facility, service is recorded as well. Reconciliation happens automatically. And then we have the dashboard at state, LGA level, and other partners sometimes have access to that. What I forgot to mention was that some of those qualitative components of the data, for example, reasons behind defaulting, that reconciliation meeting I mentioned earlier with the Mayongwa or the village head still happens. It's just that a lot of the processes have been streamlined. So when they go there, instead of doing the administrative task of, going through registers, trying to find out who defaulted and all, that one has already been handled by the system. So what they do is discuss the reasons they have the list of defaulters and the reasons behind defaulting. So the village head can have informed evidence-based data that he can use to target a specific non-compliant household. Next. Is my screen visible? Okay. So I'll quickly go through this. For each state we are present in, we have a dashboard. Am I audible? Okay.
Yes.
So we have a dashboard to the stakeholders. I'm logged in as Kano State, so I can see an overview of what is happening within all the communities within Kano State. If I was logged in as an LGA personnel, I'll be able to see only information within that LGA. Our current support for Kano State is focusing on zero dose, even though we are capturing other interventions, but the dashboard, as you can see, it's very specific with zero dose interventions. From the data that we have captured through the app, we're able to have an aggregate of first active zero dose. So when we say active zero dose, how many have been identified by the community mobilizers, referred to the health facility, but are yet to access service? We have been operating for a couple of years, and the definition of zero dose had evolved. We started with 6 weeks, so when they are due for Penta 1, but based on the Gavi definition now it's between 12 to 23 months. So nonetheless, we still maintained categorization of zero dose. So we have due for Penta. How many are due for Penta? 6 weeks to 11 months. How many are active zero dose or true zero dose, 12 to 23 months, and how many are over age? Also the demographic, how many are male, what is the average age group, what is the average distance between a zero dose household to a health facility, how many have been identified, how many were resolved, and then the line listing. So for Kano State, we're able to line list about 28,000 individuals, 20,000 children, 7,400 pregnant women, women. And then also we didn't limit the community resource group. So if they encounter men that are in need of medical intervention, they still continue with their activity of referral and tracking. Among those referred, we have about children, 22,000. So 86% of the referral is actually routine immunization, while 14% falls under others. Others could be malaria, nutrition, diarrhea, and other health services. And then women as well, majority is on ANC, very low delivery referral, and then others. Just to note that the referral number here is not unique value. A child might be referred multiple times. Health facility visit, we have about 100 plus health facility visits. We have walk-in patients that didn't come through the community mobilizers, and then we have referrals. It is important for us to differentiate that so that we can also track or accountability in terms of performance of these community mobilizers within their communities. And then also we are tracking defaulter resolution. This is quite interesting. We have a map of the households in the communities, and then again our target is zero dose. So for example, you can scroll in. The green gradient here represent 2 kilometers within a health facility. So we know whether a household, especially a zero dose household, is within 2 kilometers of a health facility. And if I'm to hover, for example, here, this red marker is a zero dose household. And we are able to see the name of the child. The reason, if you can see, reason is no felt need, and is just 2.2 kilometers away from a health facility. So this is a very strong non-compliant household that will require intervention. These are some of the information the LGA management or the village head needs to properly target that household for non-compliance discussion. And then I mentioned that we are tracking qualitative data as well. So what are the drivers of zero dose? Our highest so far is uncooperative husbands. We have no felt need, we have family problems, and then the system evolved. These are not static data elements, they kept evolving. So as the intervention or implementation progresses, new drivers kept coming up. Some of the recent drivers is unavailable incentives. There are some interventions that were giving incentive to caregivers so that they come to health facilities. And even though in some areas it has worked, but we saw drawback where if the caregiver goes to the health facility, transport won't be an issue. They will actually go to the health facility. But if that incentive is not available, they will refuse to take the vaccine, go back home because of unavailable incentive. So all this is being tracked for the government to make informed decision on how this will be addressed. And then we have also reasons for defaulting. It's different from being a zero dose. We have issues like lack of awareness, no syringes. Sometimes it's a supply side issue. So they might go and then there is no syringe or no vaccine. Poor attitude of health worker also is a concern in some areas. Yeah, so basically this is it for the dashboard. Femi will round it up with just talking briefly on the challenges. He mentioned a few.
The initial challenge we had or we ran into is performance, especially at the health facility level with many settlements under them. They easily cross the 10,000 records that is optimized for CHT. So we and the users they experience serious degradation of performance. To remedy this, newer version of CHT, in fact, I think with every new release, there has been serious performance improvement. I see you, Mr. Jones. So, and there are newer release. We're still on version 4X. We are trying to get on version 5. So we are hoping to see even more improvements from that upgrade. However, for now, what we have done to remedy the situation was to have an external service that also builds reports for each individual, metadata, not report, for each individual that summarizes their the past 3 visits that they have to the health facility. So we don't have to keep syncing those records because it's different for some stages, even for vaccination, for example, for some stages, the client or the child is expected to come back within weeks. And for some vaccines, it's after a long period of time, maybe months or even years before they are required to come back. So we have that summary of their past 3 visits in metadata, and we can easily load it on their profile. And so the health worker can see what vaccines they've taken, what vaccines they've missed, and what vaccines they are scheduled to take. I couldn't load the health worker login. We would have seen that. But that was one of the challenge we encountered and what we have done to remedy it. The second challenge was the adaptability of the user interface. Like I said, we try to get a table to present data. We couldn't do that. We have to hack around presenting the list of data using the native contact card, the way it presents data. But we also know that work is being done on making CHT more flexible, more adaptable. So hopefully soon we'll be able to show all sorts of data, maybe stream Netflix on CHT. Who knows? And the last challenge, which I'm happy to say also will not be a challenge for long, is the translation, because some of the community health and the mobilizers only understand Hausa, which is the language spoken in the northern part of Nigeria. We had to add Hausa labels to the forms, which doesn't present very well. We know that with recent versions of CHT, we can natively build interpret translations for Hausa language. So we are working on that. And so very soon, this challenge will no longer be on the list. So those are the biggest challenge we've had so far. And for every one of them, we are happy that hopefully there won't be challenges for much longer.
All right. Thanks, Femi. Because of time, I'm not sure if Josh, you have any comments related to the performance challenge that Femi has mentioned. I saw you are involved in the discussion on the forum, and also any update on when we expect the UI extension work to be ready.
Yeah, thanks, Anthony. I don't have any other comments maybe on the performance challenges, not to get us too far sidelined here. Just briefly, UI extensions coming soon. Come check out the squad. We've got a lot of work done on that one, and really hoping to probably land that in a release within the month, I think. And what that's going to allow is the ability to kind of build custom tabs in the CHT. So a web component based architecture there where you can just provide your own content that you want. You can retrieve data from the CHT data model and display that kind of formatted however you want. So exactly what Femi is looking for there, graphs, charts, etc. We're really excited about it. So thanks, Anthony.
All right, thanks. And I'm happy that also Femi is part of that squad. So looking forward to you testing that feature and making sure that it's able to satisfy your project needs. Opening up to the community just to see if there are any last question to the team.
Hi, Femi. Do you mind telling us what tool did you use to build your dashboard?
It's just a React dashboard, Postgres, using CHT sync on the back end to Postgres, then materialized views, and then React, full stack React app on top of that.
Okay, thank you.
All right, I can see a hand from Raphael.
Hello. Thank you for the good work that you've done. I just have a suggestion for the translation because I've seen that you're having double labels. Probably within your form, you can just add another column for label for the Hausa translation, and then you can import the corresponding translation file to your CHT instance so that it can switch based on the language that you've configured for the users so that you do not have to do the double labels. I think CHT supports that currently. Maybe you can exploit and you'll be able to solve your translation issue.
All right. Thanks, Raphael, for your inputs. Femi, I hope you can explore that and share feedback on the forum. And I think one of the things you could also contribute to the communities once you have been able to do the Hausa translation, you can also contribute that as one of the language that CHT can be able to support. Because of time, we can transition to the next presentation. Thanks so much to Amina and Femi for the insightful presentation.